My next guests are both doctors who see the medical field very differently. Dr. Stanley Goldfarb was Associate Dean of Curriculum and Professor at the elite University of Pennsylvania School of Medicine. He is now the chairman of Do No Harm, an organization aiming at combating discriminatory practices in medicine. Dr. Chris Purnell is the director of the NAACP's Center for Health Equity. She says privilege and politics have always been a part of healthcare disparity.
I became a public health and preventive medicine physician because I loved things like policy, politics, community, history. DEI has certainly helped me.
I was a nephrologist caring for patients with all forms of kidney disease. I think that diversity and inclusion is rather irrelevant to the goals of medicine. Unless it benefits patient care, it should not be part of the criteria for getting into medical school or becoming a physician.
Understanding a history of racism or sexism in this nation has never been a detriment to anyone receiving good, high-quality, safe care.
DEI in healthcare is dangerous because it's divisive and discriminatory. There have been a number of issues where attempts to undo what's been proposed to be discriminatory practices has actually led to worse medical care.
DEI actually is life-saving because it says, I understand your specific needs.
The most important thing in medicine is that we worry about the patients, and we don't worry about society as a whole. I think critical race theory demands that individuals be categorized as oppressor or oppressed. And I think DEI is the implementation of that. For example, the Jews turned out to be oppressors in the current era, and that's why we've had such an uprising of anti-Semitism in this country. And anyone who's been an oppressor, mostly white males, can really do no right.
Words like critical race theory, woke, and DEI have been made into slurs, and frankly is anti-Blackness, is anti-humanity. If we really had a vested interest in everybody achieving their highest level of health, we would have an all hands and an all hearts on deck mentality. And that's what health equity requires.
Thank you for being here.
Happy to be here.
Thank you for being here.
Pleasure.
I was interested in what you just said, that you take offense to people having a negative reaction to it. Do you acknowledge the fact that it has been weaponized in many situations and that faculty members, administrators have been, in some cases, severely disciplined, criticized, and canceled for even asking questions about it, challenging it, wanting to have a dialogue about it?
Let me tell you a little bit about my story. During medical school, right, my childhood hero said to me as a young Black woman who wanted to become a neurosurgeon, what man is going to want to marry you if you become a neurosurgeon, right? So immediately I'm faced with this sexism and genderism, and I don't necessarily feel that a person who looks like me or has the experiences like me is of value in that organization. Sure, I'm going to study hard. Sure, I'm going to work hard, but I don't feel as of value. And that has followed me throughout my career, despite the fact scoring well, performing well in academic environments, despite the fact taking on very senior roles. Look, during the pandemic, I was one of the senior healthcare administrators at a safety net hospital in Newark, New Jersey. We got slammed by that pandemic, right? But as
Thank you for doing that, by the way.
It was my honor. It was important for me as a Black woman to be seen, me as a Black woman physician, me as a Black woman physician leader, to be able to say to communities who were suffering disproportionately, I understand the harms of racism. I understand the harms of classism. I understand the harms of sexism and genderism. And when I did do that, Dr. Phil, I was actually disciplined. I was put under investigation at my hospital. I was told that I was being divisive. I was told that I was disrupting the fabric of the organization. So that's how terms like DEI, even critical race theory, which is an academic and legal framework, have been weaponized against those who are seeking to cultivate a shared human experience and to understand from a historical, factual, and literature influence base how we can ever eliminate the disparities that we have. Last thing I'll say on this subject, the traditionalists will say, we need to keep medicine and healthcare the way it is. Well, if we did that, people like myself and other communities would continue to live sicker and die sooner. I say we need to change and disrupt it.
What do you say?
Well, if you go to the University of Pennsylvania Medical School website, my name was wiped out because I pointed out a study that showed that minority residents in internal medicine residency programs around the country, published in Academic Medicine, the Journal of the Association of American Medical Colleges, said that they were performing less well. And I pointed that out. I say, are they performing less well? Basically in a tweet. And I was canceled for that. But I must say that, a lot of what I've heard here, I agree with. This is not about the medical profession. It's not about the students. It's about the patients. I understand there's been historic lack of opportunity for Blacks and other minorities in this country. That's a problem. And there are fields where that can be easily made up. But there are some fields where it's not easily made up. Pilot school, medical school, engineering school, things that it's critical for the health and the safety of the public. We can't be concerned about the individuals who want to practice in those fields. We can only be concerned about the outcome and the quality of service or healthcare, in this case, that patients are receiving. That's all that really should matter.
When I was 6 years old, I remember going to Chattanooga, Tennessee, and seeing whites only and coloreds only signs and having people explain to me why you needed to pay attention to that. In the same lifetime, we now have Black admirals and generals and CEOs of Fortune 500 companies and heads of foundations and university presidents. We've had a Black president. To say that we haven't made tremendous progress is crazy. Are we nirvana yet? No. Do we still have a ways to go? Absolutely. But we've made tremendous progress. And we've made that progress because of some of the values and principles that we hold as a nation. And we should look at that.
The question is, what's the fix? The question is what to fix. It's not necessarily that one thing.
It's health equity.
We have to take a break. Coming up, why Dr. Goldfarb says he doesn't believe there are minority applicants to medical school who are qualified and being rejected.
In medicine, less than 0.4% of physicians are American Indian, less than 6% are Black, and less than 7% are Hispanic. Studies show that the more diverse our healthcare workforce is, the better our healthcare system is overall. The reason why the number of underrepresented minorities in medicine is so low is intentional. In the early 1900s, for example, the Flexner Report actually led to the closure of most of the medical schools that trained Black people. It wasn't until the Civil Rights Movement in the 1960s and the Civil Rights Act that actually corrected this and allowed for Black individuals to be able to apply into medical school. Understanding the disparities helps us understand why diversity, equity, and inclusion initiatives are necessary.
I think everybody agrees that we want that. I think everybody agrees that we want to have as many people from as many different walks of life into the field of medicine. A lot of people say the reason you want that is because you have better outcomes if you have doctors that look like their patients, doctors that have that commonality. There's no empirical evidence for that. It's inconclusive, but it trends towards no, that doesn't improve outcomes. You're shaking your head.
There's an empirical study of more than 3,000 people that actually show, hundreds of hospitals that actually show decreased mortality in Black patients when there's an increase of underrepresented minorities in that population. Also studies showing the decreased infant mortality when you have increased Black physicians as well.
That's true with infants, but it is not true with the population in general. And the meta-analysis shows that it doesn't matter. What matters is the quality of care.
When there is concordance, it is proven in the data that people get better clinical preventive services, meaning they get access to screenings. For instance, cervical cancer screenings, HPV screenings. Also, people share more accurate histories because they believe that the person across the table for them has empathy. Does empathy only matter because of race or language spoken? No, but it does matter because of shared human experience.
Okay. So Dr. Phil is right.
Thank you.
I thought that would be a
Dr. Chris is right too.
Our organization, Do No Harm, has researchers that have looked at this very carefully. There are many, many studies of this issue. There are 5 systematic reviews of this issue. They ask the question, is there better communication? Is there better happiness on the patient's part? Does racial concordance really improve health outcomes? Well, there are no long-term health outcome data that are worth anything. And in terms of these 5 systematic reviews, 4 of them showed there was just no difference. You can certainly pick out a case here or there, and you can pick out an example where there's been bad communication. But there's bad communication between white patients and their doctors as well.
Definitely.
And so the question is, how can we improve healthcare disparities? Now, if you decide that the way we can improve healthcare disparities is by changing the characteristics of the delivery system, as opposed to changing the sort of things that Dr. Phil was talking about, the access to care. And I totally agree with what Dr. Reddick said. This is about improving access to care, but access goes both ways. When Black women show up with endometrial cancer, which is a terrible disease, they come with their disease far more advanced than when white women show up.
But why do they come when their disease
Well,
is
that's
far
a
more
good
advanced?
question. And that involves understanding symptoms. It involves access to care. I certainly agree. If a woman is working 2 jobs and can't get to the healthcare system, well, that's an issue. But that's not an issue for the medical.
Yes, it is.
No, it isn't.
You're speaking with the healthcare.
That's an issue. That's an issue for politicians.
Patients who were unhoused, patients who had behavioral mental health issues were showing up in our emergency departments, not necessarily because they had a clinical reason, but they had some other social reason. When we did partnerships and collaborations to get those needs met, even if they weren't purely clinical, those people were no longer using emergency room services, which was a drain on our system. So that's why it does matter.
We're talking about which physicians should get a chance to treat patients. And what you're talking about is public health issues, which is a very different world.
I disagree.
That's really been the issue here of conflating these 2 kinds of things. And my concern is that when that patient shows up at that emergency room, that person who's caring for that patient is the most qualified individual.
Exactly.
And that's the issue here as far as I'm concerned.
We've been talking about DEI programs in medicine, and if they are the right way to bring more minorities into the professions, more rural individuals into the professions, more of those that are unrepresented in the professions. Hispanics represent 18.5% of the population and 5.8% of doctors. Blacks, 13.4% of the population, 5.7% of doctors. Native Americans and Alaska Natives, 1.3% of the US population and 0.3% of the doctors. So clearly there is a underrepresentation compared to population proportionality. The question is, what's the best way to do that? I've written a book called We've Got Issues, How to Stand Strong for America's Soul and Sanity. And in there, I am very much against DEI as it is being practiced. But I think the much better approach is to get into these underrepresented communities very early on and prepare these students so they're just as competitive as anyone else. And the problem is they're often low socioeconomic status, whether they're rural or inner city or whatever, so there's a low tax base, which means the schools don't have much money to work with. That has to be fixed. They should have every educational opportunity as anybody in the United States. And I think if we intervene early, and give the educational opportunities to develop these young minds, then we can see them flourish. And I think there can be a huge shift in one generation if we get into those schools and get to those children early and give them every opportunity to develop their bright young minds.
I just want to second what you just said. That's so very important. You know, when I was a kid, and I was a terrible student until my mother made me start reading. And as I read about scientists and surgeons and philosophers and entrepreneurs, I began to realize that the person who has the most to do with what happens to you is you. But in the Black community in particular, we don't have enough people applying to medical school because we don't have that dream starting early enough. It's the early preparation that will make the difference. Yeah. And don't wait till the end to try to change things.
I agree. Dr. Reddick?
I think we spent a lot of time today talking about the D in DEI, and specifically racial and ethnic diversity. So I think one of our shining examples of DEI happened in California with maternal mortality, where they had a maternal death rate that was about 4 points above the national average, dropped it down to 14 points below the national average. So in the United States, you're more likely to die in childbirth or pregnancy compared to other industrialized countries.
If you're 50th.
Yeah, and if you're a Black woman, your rate is 3 to 4 times higher than the rest of the population. They were not only able to decrease just overall maternal mortality, they decreased Black maternal mortality with specific system changes. That is a classic DEI initiative and something we should be proud of. But instead of talking about that, we focus on things like medical school admissions. And then the second thing I want to just piggyback on what Dr. Goldfarb said was this idea of like, we shouldn't be focusing on some of these social and political issues. And what we found out is that social determinants of health, which are the non-biological things that affect health outcomes, actually have a bigger influence on health outcomes than even clinical care. So in my clinical care that I practice at a healthcare for the homeless clinic. So every single week I address people's social issues. And I think that is a role of a physician.
Mm-hmm. Well, final comment?
And the focus has to be on making sure that the patients get the optimum care. And if you start compromising on the academic potential of the individual that you're letting into medical school, you're going to lead to the kind of data that we see, which are many, many minority residents and trainees are just not performing as well as we had expected that they would. And I think in part it's because we've compromised the quality of the individuals that we're taking in. There are plenty of incredibly brilliant Black students who could be terrific physicians. They should be the ones that have the same academic potential and the same academic achievements as anybody else. And then the basis should be on their ethical statements and their empathy and their kindness. These are all critically important parts of a physician after we've identified the ones that have the greatest academic achievements.
Yeah. Final comment?
Yeah. I think it's so important that not only all of us, but that the public understands DEI is only a tool, the roadmap to build a more just healthcare system that's inclusive. Because if we don't do that, we will never solve the healthcare disparities that we have. And finally, to stop focusing on the red herrings that those who are of different communities and different ethnicities are less qualified, but to look at the barriers that are impacting whether or not we are reaching into those communities and mining them for all the success that they have. That's the American dream we all should be focused on.
I want to thank Dr. Ben Carson, Dr. Bonzo Reddick, Dr. Stanley Goldfarb, and Dr. Chris Purnell for joining me tonight. And thanks to you at home for finding us here on Merit TV. We spent extra time discussing this topic, and some of what did make our broadcast will be on our website, and we'll have even more information about tonight's show. So make sure to log on to drphil.com. This is important, and one of the dumbest things somebody can do is waste a talent pool, like the Black talent pool, the rural talent pool. And I promise you, those organizations that do that because they're racist or they're judgmental or whatever, in the long run, they won't compete well because they will miss a huge, huge talent pool. But in the meantime, we need to do what we can to find the solutions. I told you what I think my solution is. I think we can make a huge difference in one generation. Thanks for being here. We'll see you next time.